In early 2008, we had several patients that died as a result of poor management of their diabetes. We had several devastating events with prolonged hypoglycemia that resulted in permanent brain damage, and the patients ultimately died. And we realized then that the care we were providing to these patients was clearly not what it needed to be.
People with diabetes tend to have a longer length of stay in the hospital, and the longer you're in the hospital, the more that costs the system. And there's also a greater risk of complications in the hospital. Infections don't heal as well. People are more prone to get infections. Wounds don't heal as well.
We had sort of tolerated poor control of hyperglycemia and viewed episodes of hypoglycemia as just a rite of passage for being in the hospital. You know, poor control happens, we'll just live with it. And then we realized what a bad impact that had on our patients. We said this has to change. We developed a easy-to-use, weight-based basal bolus insulin order set within our electronic medical record. We did drive things down quite a bit to below 20% for hyperglycemia and down to less than 2% for hypoglycemia. But we found we were sort of hitting a brick wall. We had a very massive educational effort in 2008 and 2009 when we launched this effort, but over time with turnover, some of that education fell to the wayside, and we saw a decrease in our results.
We have better paper protocols nowadays than we had 20 years ago, but it's still difficult to write a paper protocol that can adapt to each individual patient, because patients vary so much in terms of their insulin sensitivity.
What we felt was we needed to get a tool that can be hardwired into our system, that's easy to use and adapts to the patient's varying needs. Three main things are, and not in any particular order, but ease of use for the frontline staff, a sound, safe algorithm, and then operability within our electronic medical record. And that's what we get with Glucomander.
I mean, it's easy to have a protocol and say, if the blood sugar does this, do this. But what happens if the blood sugar drops dramatically? You have to be able to adjust the protocol to fit that patient, and Glytec sort of learns on each patient as the insulin drip is progressing how sensitive or how resistant that patient is, and really conforms to that. Within Epic, nurses can click on the link to Glytec and start a patient on the Glytec system to put them on insulin, whether it's IV or sub-Q, and not to have to constantly run back and forth between two systems and two computer screens. So it's nice to have it all integrated.
Our goal is to have, again, no sugars over 200 milligrams per deciliter within the first several post-operative days. And in fact, since we've been using Glucomander, we have not had any glucoses outside of that range, which we're very excited about. Because before that, we were chasing it, and we had quite a few sugars outside that range. Our cardiac surgery ICU unit, we're seeing a hyperglycemic rate that's 5 to 8%, which is incredible. And at the same time, we're seeing a hypoglycemic rate that is about 0.5%. So you're not using the standard of care or delivering the standard of care when you're not using Glucomander for the care of your patients.
To me, it's not only a quality benefit for patients, a safety benefit, but also a huge economic benefit, I think, to the extent that we've been able to manage difficult, complicated patients in a very safe and efficient way. Oftentimes we put patients in the ED who come in out of control on the Glucomander, on IV insulin, get them down to a safe, normal, or close to normal blood sugar, and often these patients are stable enough to go home. So we're, in many cases, preventing admissions.
There's research out there that improving glucose control does reduce length of stay. We calculated a very strong business model based on that reduced length of stay that really made it a no-brainer to move forward with this platform.
I'm sure it's saving the hospital millions of dollars because of being able to do a lot of what we do in the ED, in the units, not having to use the ICU always. So that's been very helpful.
We're definitely revolutionizing glycemic management with Glytec. There's no doubt about it.